È per me un grande piacere introdurre la lettura del professor Alain Godric. Alain Godric è una persona che non ha bisogno di molte presentazioni, però a me tocca il compito e l'onore di dire alcune parole che non potranno che essere riduttive rispetto alla professionalità di Alain. Alain è forse il primo o meno, primo o secondo, ma insomma se la battevano, allievo del professor Coscas, insieme se la batteva con Gisèle Soubran, che era più o meno coetanea, credo, la même âge de Gisèle ou pas? Ton âge, c'était la même de Gisèle?
Un peu plus jeune.
Tu étais più giovane. Aveva appunto questo ruolo di braccio destro di Coscas. Io l'ho conosciuto nel 1984 quando sono stato a Parigi a Créteil presso di loro, e devo dire che Alain era realmente il pozzo di scienza, cioè era quello che faceva tutto a un livello eccellente, dal trapianto di cornea alla chirurgia vitroretinica. Lui sapeva fare tutto benissimo. E a differenza dell'idea che spesso si ha del chirurgo maneggione, che fa ma non pensa, che fa ma non studia, Alain Godric sapeva tutto di tutto. E io mi ricordo una cosa in particolare, che avevo trovato presso la clinica di Créteil dei casi di regressione spontanea della retinopatia diabetica proliferante, e dopo averli collezionati, dopo aver studiato, dopo essermi guardato la letteratura, lui non sapeva niente di questo. Mi presentai da lui nella sala Anjou, dove facevano le refertazioni delle fluorangiografie, gli feci vedere questi casi e gli dissi: guardi, la letteratura è questa sull'argomento. E Alain mi disse: però non hai messo il paper di, non so che cazzo era, di qualche anno prima, che lui ricordava perfettamente senza che sapesse su quale argomento avremmo dovuto confrontarci. Sapeva tutto e sa tutto, perché poi quello che lui ha avuto è un entusiasmo per la scienza oftalmologica che è rimasto immutato per tutta la vita, e anche adesso, che è già in pensione da qualche anno, continua a produrre scientificamente, e uno dei contributi più importanti, più recenti, è quello che ci presenterà oggi, pertinente la valutazione angio-OCT dell'ischemia retinica in corso di diabete, per verificare quello che, con una grande fake news, i colleghi americani avevano sparato nel nostro mondo come un dato di fatto acquisito, e cioè che fare gli anti-VEGF consentiva di far regredire la retinopatia proliferante, perché secondo loro c'era anche una regressione di tutto ciò che accompagnava la proliferante, ivi comprese le ischemie retiniche. Questo non è, e lui lo ha dimostrato per primo sbugiardando questo atteggiamento mentale, e ha contribuito in modo sostanziale alla conoscenza in questo settore. Sono quindi felice che lui sia qui, che abbia accettato l'invito di S.I.S.O. Io gli sono grato per quello che mi ha insegnato quando io ero lì, e per quello che ha continuato a insegnare a tutti noi negli anni successivi, e lo ringrazio ancora di essere qua. Grazie Alain, merci bien pour être ici. C'est un grand plaisir d'avoir toi ici.
Thank you, Francesco. I've not understood all what you have said, but probably it's too kind. Thank you again. And good afternoon, and thanks you to the organizer of this first very successful S.I.S.O meeting, and especially to Professor Bandello for inviting me to give this talk. So I will briefly see with you if we are ready to assess diabetic retinopathy severity on OCTA, and ask the question, what is important, the macula or periphery, or both? I have nothing to disclose. In recent years, there has been renewed interest in the examination of the retinal periphery in diabetic retinopathy. Editorials, original studies, general reviews have pointed out that new imaging techniques make it possible to examine easier than before the retinal periphery and provide valuable information. At the same time, the emergence of OCTA technology has made it possible and easy to measure capillary density in the macula. Okay, it's better. Okay, fine. No problem. Merci. Thank you. In the macula, and several publications have shown that the decrease in capillary density in the macula is proportional to the severity of diabetic retinopathy. Various parameters have been tested, such as enlargement of the foveal avascular zone, FAZ, capillary density, and inner capillary areas, and various capillary levels of the macula. They have confirmed all a relationship between the capillary density decrease in the macula and the severity of the diabetic retinopathy. Among these publications in 2015, Nadia Wahed's group showed in a cross-sectional study that changes to the FAZ and capillary non-perfusion were more prevalent in diabetic eyes. 4 years later, in a prospective study, they showed that the FAZ area and deep capillary plexus density predicted diabetic retinopathy progression, whereas vessel density of the superficial capillary plexus predicted the development of diabetic macular edema. However, on the basis of these studies, should it be considered that macular vascular density and FAZ surface can replace fundus examination to grade diabetic retinopathy? Over the last 5 years, there has been many changes in the assessment of diabetic retinopathy severity. The accuracy of ETDRS grading system has been questioned. Ultra-wide field color photos and fluorescein angiography have revived interest in examining the retinal periphery. The correlation between peripheral lesions on color photos or fluorescein angiography and macular capillary density on OCTA were studied. For instance, in 2015, Silva and Aiello showed, using ultra-wide field imaging, that predominant peripheral lesion, PPL, that is microaneurysm, microhemorrhages, ERMA, are associated with an increased risk of diabetic retinopathy progression and correlate with non-perfusion index on ultra-wide field fluorescein angiography. From these observations, Silva et al. Stated that PPL may be used as a guide to the extent of peripheral non-perfusion. This conclusion reinforced the idea that ultra-wide field color photos may be reliable enough to grade the progression of diabetic retinopathy. On the other hand, ultra-wide field fluorescein angiography improves the detection and classification of diabetic retinopathy, as it is well illustrated by this case, where many new vessels are outside the 7 fields of the ETDRS. Thus, several publications have extrapolated from fundus color photos that diabetic retinopathy may regress under anti-VEGF treatment. For instance, a randomized clinical trial showed that eyes receiving anti-VEGF may improve the severity of diabetic retinopathy. In another publication, the authors also conclude that the severity of diabetic retinopathy regressed under anti-VEGF. However, Sophie Bonin in our department showed that regression of hemorrhages under anti-VEGF treatment did not correspond to any improvement in capillary perfusion on ultra-wide field fluorescein angiography. This means that the risk of neovascularization persists if the anti-VEGF treatment is discontinued. For instance, in this case of early proliferative diabetic retinopathy, most of the hemorrhages cleaned up after 3 monthly injection of anti-VEGF. New vessels regressed, leakage decreased, but no reperfusion was observed. It's especially the case in this area, where ERMA regressed, as well as hemorrhages, but where no reperfusion occurred. This case shows that grading diabetic retinopathy severity on color photos solely may not be relevant when applied to changes in the fundus occurring after anti-VEGF treatment, a situation which, of course, was not anticipated by the authors of the ETDRS classification. We have also explored with Ose Couturier how wide-field OCTA compares with ultra-wide-field fluorescein angiography to detect capillary non-perfusion. For instance, in this case, new vessels that were present at baseline on both fluorescent angiography and OCTA have regressed at 3 months, but the areas of non-perfusion have remained unchanged, as shown on OCTA, even better than of fluorescent angiography. So, is it time to use wide field OCTA instead of ultra-wide field fluorescent angiography? Indeed, while the value of examining the periphery in diabetic retinopathy is generally accepted, ultra-wide field fluorescent angiography cannot be routinely performed, and ultra-wide field color images have limitations. So, if wide field OCTA, is wide field OCTA already the solution? In this perspective, in order to elucidate whether detection of retinal lesion on color images is equivalent to the detection of non-perfusion on OCTA, we compare the number and location of red spots on the color images with the location of non-perfusion area on wide field OCTA. Red dots were counted on a 90-degree color photos. Then OCTA montage was superimposed on the color photo, covering a surface a little bit smaller than the ETDRS fields. The map of non-perfusion was then superimposed, and lastly, the map of red dot count. Here are the results. As expected, the number of red dots and the non-perfusion index increased with the severity of diabetic retinopathy. However, while the standard deviation of non-perfusion area was low in cases of mild and severe in PDR, the standard deviation of the red dots was very high in case of severe in PDR. In other words, for the same amount of OCTA non-perfusion, there was a high variability of red dots on color photos in severe in PDR, underlining the limitation of using color photo to assess the extent of non-perfusion in diabetic retinopathy in a particular individual. Another way of assessing the periphery is to measure a non-perfusion index. It has been done by Nadia Waheed's group, who stated that the area of capillary non-perfusion in the posterior pole increases with increasing severity of diabetic retinopathy. However, they had that further OCTA studies are required to better understand the distribution of non-perfusion as a function of distance from the fovea. We have also tried to compare the non-perfusion index in severe non-PDR and PDR in order to see if there was a difference between these two stages of diabetic retinopathy. The non-perfusion area was detected by an automatic algorithm with manual correction. The results show that the non-perfusion index was higher in PDR than in severe in PDR, while there was an overlap between the two groups. In consequence, it remained difficult to establish a predictive threshold for neovascularization. Another publication has questioned the relationship between non-perfusion area and the severity of diabetic retinopathy using different field of view of the Plex Elite swept source OCTA. The values obtained with a field of 10 by 10 millimeter was more predictive than those for smaller fields. These results refer again to our original question. Are measurement of the vascular density in the macula sufficient indication of the severity of diabetic retinopathy? These recent studies carried out by the ILO group report that vascular density of the macula on OCTA is not associated with the severity of diabetic retinopathy in eyes with predominantly peripheral lesions on color photos. The reason for this discrepancy is not fully understood, but it could be due to the weak correlation we have observed between peripheral red dots and the areas of non-perfusion. Two other recent papers have comparatively studied vascular density of the macula and periphery. Matropasqua studies found a good correlation between central and peripheral capillary density. But Ricky Wang's group, using a 100-degree field OCTA, showed that the most peripheral sectors has a higher non-perfusion than the central sectors, and the author concludes that the measured non-perfusion in the peripheral field gave the best results in the evaluation of the severity of the diabetic retinopathy compared to the more central field. We also try to answer this question in comparing the ratio of vascular density between the central 3 by 3 mm and other 3 by 3 mm areas located in the mid-periphery at about 7 mm from the center. We also calculated in each area the percent of capillary loss compared to the normal value. The results showed that the ratio mid-periphery vascular density versus central vascular density was higher only in the deep capillary complex of eyes with moderate to severe NPDR compared to no or mild NPDR. In other terms, only in the most advanced stages of diabetic retinopathy, the decrease of vascular density was higher in mid-periphery compared to the center, but only in the deep capillary complex. Also, no significant difference was found in the superficial vascular complex. Similarly, compared to normal value, the vascular density loss was more important in the deep capillary complex of the severe NDPR case in mid-periphery. What does it mean? It means that in the superficial capillary plexus of diabetic eyes, vascular density loss was homogeneous between the center and mid-periphery, while in the DCC, vascular density loss was higher in the mid-periphery than in the center in eyes with moderate to severe NPDR. It is then possible that vascular density loss in the superficial capillary plexus of the macula is predictive of peripheral non-perfusion, but the vascular density loss in the deep capillary complex of the mid-periphery could be an additional alert for the risk of peripheral non-perfusion. However, all these studies are limited by the fact that the field of view of today's wide-field OCTA is not large enough to examine the periphery to the equator. Fortunately, technical progresses are underway. The new Canon Xefilio has a 23 by 20 mm field of view compared to the 15 by 15 of the Plex Elite. Compared to the Optos image, a Plex Elite montage gives an interesting field of view, but the montage of 5 images of Canon Xefilio covers almost all the field of the Optos image. As you can also see in this comparison with ultra-wide field fluorescein angiography made with Optos. In conclusion, the measurement of vascular density in the macula allows to diagnose diabetic retinopathy and gives an indication of its severity. However, it is unlikely that the estimation of the risk of neovascularization can be solely based on the assessment of capillary density in the macula. Comparison of vascular density in the macula and the periphery on OCTA suggests that the vascular density decreases more in periphery than in the center. Wide-field OCTA has a potential advantage to measure capillary density in the macula and to calculate an ischemic index, although its field of examination is not yet large enough to compete with ultra-wide-field fluorescein angiography. However, the data already obtained support the need for an updated diabetic retinopathy staging system to incorporate relevant advances such as vascular density. And I would like to quote also this editorial which appeared last year in Retina, signed by Lee Jampel, Ramin Tadayoni, and Michael Heap, which concludes that a new diabetic retinopathy classification is needed for a more accurate assessment of the progression of regression of diabetic retinopathy response to anti-VEGF therapy and prediction of visual outcome. Finally, we need a critical view on the advantages and limitations of the OCTA. Recommendations have been made by a panel of international experts to report on OCTA in retinal diseases, paying attention to the limitation of this technology, which nevertheless remains extremely promising. The recommendations are to define a large flow decrease by 30% of the absolute image area, define a meaningful change in the percentage of flow on wide field OCTA as an increase or decrease of 30%, include OCTA in the assessment of diabetic retinopathy severity and progression, the assessment of intravascular abnormalities and the vessel density should be added beyond the already recommended parameters such as presence of neovascularization for very vascular zone parameters and the presence of no flow areas. OCTA is a still evolving technology, and we can hope that in the near future we will be able to classify diabetic retinopathy not only on indirect signs, red spots, cotton wool spots, edema, but on the features of the microangiopathy itself. I would like to thank my colleagues, Dr. Sophie Bonin, Aude Couturier, Bénédicte Dupas, Ali Arginet, Carlo Lavia, who is now in Torino, Ugo Le Boité, Loïs Torres, Professor Ramin Tadayoni, e grazie per l'attenzione.